Hello and welcome to another Mental Health for All webinar. I'm Niall Boyce, editor of The Lancet Psychiatry. Now, the past year has not been one packed with highlights, but collaborating with United for Global Mental Health on these events has definitely been one of them. Now, those of you who joined us 2 weeks ago, and if you didn't, don't worry, you can catch up on the website. But those of you who joined us will remember that we talked then about the effects of COVID-19 on the brain and the mind. Today, we're taking a broader outlook. We're asking how mental health services and public health have changed in response to the virus, and we're asking what changes still need to be made in the shorter term and the longer term. As ever, the most important thing is that you get to ask the questions. So please go ahead, put them in the box, and we'll get around to as many as we can. And if you'd like to tweet about us, please feel free using the hashtag MH4All. But first, I'm going to introduce our guests for the panel discussion, and I'm completely delighted by our panel today. We're joined by Florence Baingana of WHO, who's a psychiatrist and a public health specialist. We have Carmen Moreno of the University of Madrid, who is a child psychiatrist who's looked specifically into the issue of mental health services in response to the virus, and also by Nev Jones of the University of South Florida. Now, Nev's area is stakeholder involvement, and she has a reputation as one of the most thoughtful commentators on the whole subject of the philosophy and the practice of mental health services. So welcome all to the webinar. I'd like to start by turning to Florence and asking for some background on this issue. What's your assessment of the public health response to COVID-19?
Thank you. And I will be focused on the mental health response to COVID-19. I believe you may have discussed last year about the COVID and mental health survey that WHO carried out, but I will go over those results again. So I guess the highlights, what this survey highlighted was that while most countries actually do know what to do, most countries do have a mental health and psychosocial response. Unfortunately, only 17% of countries had fully funded the response plans that had been developed. This is at a global level. For almost all countries, there were disruptions in services. These disruptions were most felt for children and adolescents, as well as for counseling services and for harm reduction services. Many countries reported that when it came to repurposing some of the mental health units, often it was the alcohol drug treatment programs that were repurposed to COVID. So then the people who needed care couldn't actually access it. And then the final point I'll make has to do with how countries responded. So because of the restrictions that we have, the social distancing and travel restrictions, it made sense then to move to telemedicine and to move to telephone counseling and treatment of patients. Telemedicine was the commonest strategy used in the high-income countries. Up to 80% of them reported using this response, but less than 50% of low-income countries actually could or did take up telemedicine as a response. And we know this is related to the inequalities in coverage of internet coverage, smartphones, computers, as well as the skilled manpower to use these kinds of resources. So I'll stop there for now.
Yeah, I'd like to follow up really on this issue of the inequality of provision. Now, we know that a lot of clinical services have been affected by the shifting around of priorities which governments have carried out because of the pandemic. We know, for instance, that this has affected cardiology services, oncology services, but have mental health services been disproportionately affected in this process?
Yes, mental health services were disproportionately affected, I would say, mainly because there was a sense of they may not be at risk, and therefore they were often the last to be provided with personal protective equipment. And that was unfortunate because people who live in long-stay institutions are actually much more at risk than those who stay in short and turn around much faster, or who could get their care from home. People with mental health conditions often were affected in that sense.
So really, once again, what we see is, for all the talk about mental health being a priority, it's still seen by some as being optional, or even as a luxury, not an essential service. And I'd like to turn now to Carmen and ask, has that been your experience as well of how mental health services have been affected by the pandemic?
You know, I really think it probably will be seeing an effect of time on this way of how we've seen services affected by this situation. What I have researched and what we've seen is that the first response has been to turn to other services as priority services. We've had to do other things prior to protecting mental health. That's what health services in general have done, and that's understandable because you know, this priority of tackling the needs of the virus and the ICUs and the emergency rooms that the virus. The problem is that very shortly, we've seen that the services of the mental health have been broken. And with all this community care that is so important in sustaining mental health of these people that are more vulnerable even to the virus itself and more vulnerable to be dying from the virus have been broken. And it's broken the relationship between mental health and primary care. It's broken the continuity of care, hospital care, so on and so forth. So one of the big issues has been, on the one hand, I would say, to adapt the way we've been delivering mental health to the virus, protecting and so on and so forth, as Florence just mentioned. I believe this is something that everyone has had to do, and we didn't have equipment at the first, and now there's more and more knowledge on the need of equipment, although it's still not good enough for everyone. But on the other hand, we have had to pay attention on how to continue working with our patients, with our clients. And this has been a completely different story. So how to not only do telemedicine, how to coordinate with other providers, how to coordinate with social care, how to coordinate between the different members of a family that are not equally used to get into technology, how to decide who needs technology and who you cannot use technology with, because there's some people who it's not a good thing just to shift the care to that, and how to evaluate how these things are really working or not. So I would say that it's a matter of flexibility, of being able to really put mental health in the place where this needs to be. And there's another thing that has to do with new people needing mental health care. So all I mentioned is for these people that already were in treatment, that were referred before, or that would have been referred in any case. But we have new users. And I think that's another important aspect that we need to take care of.
Yes, and one of the things which I've noticed is that when mental health is mentioned in the context of the pandemic, inevitably it is on the topic of anxiety, of depression, of mood disorders. I really haven't heard much about other conditions such as psychosis and what effect this has had. And this seems to me to be really reproducing and perhaps widening the inequity in resource and in the conversation and attention that people were paying in terms of mental health even before the pandemic. Would you say that's the case?
You know, that's a very interesting question. There's been a number of publications on that, and we've been noticing that on the one hand, there's some cases of psychosis that are triggered by stress, and that has been there has been an increase in that, and we've seen that in the words, and this has been, there's some publications in Spanish groups of research. We also know that all this situation may also trigger other not only stress-related, but big psychiatric situations such as psychosis. But we also know that, as has happened before with other virus infections, this can be a problem for the future, for future generations. We know that the pregnant women being infected may be at high risk of having children with neurodevelopmental problems, and psychosis is one of them, not the only. So we really are in a situation where not only thinking in the short term, but thinking in the mid and in the long term, we may have psychiatry and psychiatric important problems, just psychosis, as you mentioned. They are in a spike now, with an increasing incidence and increasing problems of management.
Again, what Florence said, which is about the growth of telemedicine, of digital mental health services. And, this has been, I think, one of the success stories of the pandemic. I know that I've heard it said that there was more progress in the first 10 weeks of the pandemic in terms of digital mental health than there had been in the previous 10 years. But of course, digital mental health is not the panacea for everything. And I wonder, Nev, if there's a risk that some patients might actually suffer disadvantages as a result of the shift to digital.
Absolutely. And I think there has been a lot of, kind of discussion of the way in which, kind of COVID and the move to telehealth may have exacerbated existing digital divides, which we see, in rural versus urban populations, among people with more extreme levels of kind of social disadvantage regionally and globally. I think what's gotten less attention, at the risk of sounding sort of overly Marxist maybe, is who kind of controls the means of production and the way in which we see kind of hierarchies which already exist, which sort of tend to subordinate or subjugate service user views, views, and especially more grassroots work coming out of low and middle income countries, is sort of right, like sort of who has the resources to actually sort of build and develop technology, especially when we move out of sort of telehealth into apps and different forms of kind of digital health interventions. And I think that there's a real sort of risk of kind of colonization happening here, again, both of sort of more emic kind of service user driven ways of thinking about mental health and healing, but also globally. So I have seen a whole stream of publications or new kind of funded grants that essentially kind of digital work that has developed in high income Western countries and is being sort of now put forward as a solution to sort of global mental health problems, ostensibly maybe with some local partners. But I think there's a lot of questions about who is really driving the kind of conceptualization of mental health and healing implicit in that technology, which is only sort of partially adaptable to local context. So those are big concerns of mine.
Yes, well, one of the original sins of psychiatry, if you like, is the power imbalance, is the imbalance between the clinician and between the patient. And of course, the imbalance globally, as you say, in terms of ideas about mental health, which have their origins in Western Europe and the US, then being exported unquestioningly around the world. And I have to say that those power imbalances may be pale in comparison with the current power imbalances which exist between populations and the digital giants. So what you seem to be saying is that these two could really form an unholy alliance, if you like, to perhaps offer us innovative ways of reaching people, but also maybe unthinkingly reproduce the kinds of power imbalances which have been very bad for psychiatry in the past and would be terrible for it in the future.
Absolutely, and I think just to sort of make what you're saying a little bit more explicit, it's this, kind of historically, I mean, big pharma, the pharmaceutical industry obviously has been the sort of subject of a lot of kind of criticism and concern. But here we have kind of big technology, and often the maintenance costs behind, especially, not just sort of telehealth, but behind applications and different kinds of tech interventions sort of require, kind of commodification, or, even universities often sort of quasi kind of privatize or spin off technological products and interventions. And so you have sort of, big technology wielding this sort of oversized role in how that plays out. And it's a source of major concern. And I think concerningly, we're not discussing that nearly enough. And this is one thing that where COVID maybe plays a problematic role. These gears were already in motion before COVID, but COVID has absolutely sort of accelerated this push for technology and technological solutions, and under kind of decisional timeframes that are too rapid, I think, to kind of really slow down and think much more deeply about the implication of where we're headed with all this technology, and what the implications will be.
So it's not enough for the mental health community to simply use these tools, but we've also got to recognize our roles as stakeholders in their development as
Absolutely.
well, and insist on that. Thank you. So I'd like to look to the future now, and well, to the next 12 months perhaps. So Florence, looking at the next 12 months, what sort of public health issues do you anticipate will emerge, and what can be done to tackle them?
Well, over the next 12 months, as we are seeing already, we are getting a resurgence of the new cases globally. This may be because people maybe last year was not easy, and now they feel like we just have to get on with it. We have to live with it, and all flights have been reinstated, and so we are getting lots and lots of new cases. But at the same time, many of the nations have actually reinstated lockdowns and other mitigation measures, and that seems to be like we are going backwards. The new cases, it also means that we have overwhelmed healthcare systems. We have fatigued and stressed responders. The responders who have been at the front lines have been at the front lines for 1 year. They are now starting a second year of this very high, intense work where they are in the, always at risk almost. A colleague was telling me she's tested almost every other week, because when one person in the team tests positive, everybody else then has to get a test, and that's a very difficult way of working. We also have the increased cases means increased deaths, therefore an increased number of people who will be mourning and grieving their loved ones who have passed on. We also have increased survivors, because we know the death rate is 3 to 4%. Therefore, the big majority of people who survive are going to survive with some are saying they get maybe PTSD, post-traumatic stress disorder. We have the long haulers, those who get long COVID, and more. We're going to see more and more of those. And a lot of the symptoms are mental and neurological. And therefore, I think to sum it up, we're going to be having an increased demand for mental health services. And last year, this was being predicted, but I'm not sure how seriously this was taken. So while today we have to respond to the emergency, but at the same time, we need to be looking ahead and saying, are we ready for this chronic and ever increasing mental health burden that we are going to be having to deal with?
And even if we do take a longer view, I mean, 12 months isn't enough time to train a lot of nurses or therapists or psychiatrists. Global mental health has really shown the success of what would have been called task sharing or task shifting approaches to really, quickly train people in the essential skills to deal with a large number of mental health problems. Do you think that this is an approach which maybe high-income countries can learn from the successful rollout of these schemes in low-income countries and middle-income countries?
Oh, well, before I comment on that, there's something I did want to talk about telemedicine as well, because we tend to believe that telemedicine and artificial intelligence, that's the term I'm looking for, is going to be a panacea going forward. And yet the crux of the field that we work in, health, not just health, but especially mental health, is about sitting with somebody and making a physical connection, not touching, but you see them face to face and you make that connection through eye contact, through observing also the body, the movements, this and that. And if these things are not happening, if all the connections are going to be through the computer, I feel like there's a gap there as well. But when we come to task sharing, yes, definitely there's a role to play for task sharing, especially at the community level. If we have a lot of survivors who are going to need care in the home, is it possible then to create the peer-to-peer support groups, maybe facilitated by somebody who is a bit more experienced? Is there a role for that? Is it something, again, that can be done through Zoom calls, video calls, and things like that? Because I know now that AA has been holding their meetings via Zoom calls. Is it something we could replicate as well? So there's potential definitely for task sharing and task shifting, but at the same time, we do need to have the specialists. I think we tend to think task sharing will answer everything. It won't, because when you task share, you do need to have the supervisors. Otherwise, you task share, and then when there's a complication and they can't manage that problem and they have nowhere to refer, then the whole system collapses.
Thanks. So we've got to be careful, in other words, that we don't come up with solutions which look good on paper, but then practically break down because of gaps in knowledge, between gaps in the actual system in terms of referral. So it's quite a task ahead of us, it sounds like, from your point of view. So I'd like to ask Carmen now. We've talked about various innovations in service delivery, of which digital is one. It's not the only one. Do you think that once this pandemic is over, as we hope it will be very soon, what innovations should we keep? Which innovations could really help to transform mental health services going forward, even without a pandemic going on?
Well, I don't really know if with the COVID we are going to have a completely different mental health scenario. So I really feel that the needs are going to be increased, but are not going to be absolutely different to the needs we already know. As we mentioned before, we know we already have some groups, and as also Florence mentioned, those people that are grieving, those people that lost relatives, those people that had COVID, that will have particular mental health needs and that should be addressed probably in multidisciplinary teams, because they are going to come along with chronicity of physical illnesses. Or those people that are on the front line that will have continuous stress for a long time and that are not even grieving now because they keep on working in a very efficient way and didn't have the opportunity to do so. So I really think that one of the things that we should see is that there are more mental health necessities now than were before, that these mental health necessities are going to be there for a long time, and that we need to pay attention to those, even with what we've got now, not inventing anything new, just to pay attention to that. If we go to innovations, probably besides these new ways of relating with patients, that absolutely agree that needs to be rethought and that need to be discussed in an ethic, legal, therapeutic arena in more depth now, and to refine them and to decide when and for who and for what time and for what are needed and useful, and we need to look at that. We also need to reinforce community mental health treatment. I think this is a moment to rethink that maybe we need to shift the way to deliver care for inpatient units to home-based treatments. There's the moment to think what are the strengths that we may have in the community for some cases and to bridge with them. Of course, it doesn't mean that psychiatric needs are going to decrease. They are going to be there. They are going to be increased. We've seen that we've got not only more cases, but that these cases are the top of the iceberg because these cases are more severe than the cases we've seen before. We are seeing very young people with suicidal ideation, with suicidal attempts at very young ages. We didn't see that before that frequently now. We know that's going to be there. It's not to be creating alarm, but this is a reality. So one of the problems we're having now is that we didn't get enough from the primary health providers because they are not in such a good shape just to be taking care to everything. So coordination, maybe using this telehealth, these ways to create a sustainable way of coordinating is going to be even more important than using that only for the part of connecting with patients. Using webinars such as this one for discussing cases, for thinking through treatment plans, for organizing the work, for supervising and taking advantage to that, it's going to be crucial. And also to take into consideration not only the needs, but also the people in need. So we need to include those people attending visiting us, and families and survivors into decisions to decide what is going to stay, what should be staying, and what should be deleted and not pursued. And for doing so, we need to decide what we are going to test and what we are going to be looking at. It's not this. So there was something that was said before about the mask, wearing masks. Should it be done? Shouldn't it be done? Is this a political decision? We should be putting science first and making decisions on what to stay and what should be dropped based on science. On providers and users, but on science for sure.
Thanks. Now, Carmen, I'd like to take one thing which you said, which is that people are going through all sorts of difficult experiences at the moment, including job losses, bereavement, social isolation, and so forth. Now, I have heard the argument made that these difficulties are really nothing to do with mental health or mental health services, that these are essentially normal responses to stressful situations, and it's not really helpful to frame them in terms of mental health. Now, Nev, I'd be very interested to know what your views are on that.
So, right. So I think there's sort of, two sort of arms to this. One is the sort of the risks of sort of pathologizing expectable reactions or responses to stress. And then, I mean, we know that that can sort of set off a chain for some people that may lead to sort of sustained mental health challenges that are more sort of recognizable as kind of conventional psychiatric problems. But for many people, that's not the case. And there is certainly a risk there. At the same time, I almost see this sort of countervailing tendency, which worries me in a different way, which is that we have so embraced this sort of universalist, generalist language of mental health that we're actually sort of moving away from a sort of more pathologizing framework, which on the one hand is maybe good, on the other hand, as you've pointed out in kind of one of the early Lancet Psychiatry editorials, is that there has been a real neglect of what we would conventionally call serious mental illness. And that the emphasis on sort of mental health awareness rarely includes any kind of robust substantive attention to really sort of changing the sort of the conditions, whether of kind of services or the sort of broader lives of people with kind of sustained long-term serious mental health challenges.
Yeah, I mean, there has been this shift of mental health versus this, I think, valid but somewhat nebulous concept of well-being. And that's one thing which I've noticed. I mean, do you think that the pandemic has changed, will change public attitudes towards mental health, or will it change mental health more towards public attitudes, if you see what I mean?
I think it has, in a certain sense, normalized mental health challenges in this very sort of the mildest sense, right? This sort of collective understanding that people are stressed and struggling, and that sort of falls comfortably under the umbrella of mental health, and then is sort of a far cry from what people in institutional settings with, again, sort of quote unquote SMI, people who are homeless on the streets. So there's this whole other reality of, I think, how COVID has impacted, kind of people with those, with that whole sort of set of experiences and issues and all their sort of societal repercussions. And, again, it's not, I don't see COVID as having sort of radically changed anything, but more kind of accelerated kind of tendencies, cultural tendencies that preceded it. So again, it is this sort of further neglect of more serious mental health issues in place of let's all embrace mental health, everybody's struggling, sort of everybody has depression or feels depressed some of the time, everybody feels anxious some of the time. And it's good. It's good and bad. I mean, I think sort of normalizing mental health in this very generic sense, there are good aspects to it. I think the ongoing sort of exclusion and neglect of quote unquote SMI is very problematic.
Thank you, Nev. Now I'm going to turn to the questions which our audience have sent in. And there's some good ones here. So the first one which I have is from Singapore. This person says, in Singapore, I see more politicians weighing in on the importance to invest in mental health during this period. How might we avoid making it just a phase in talking about mental health? I think this is the question really about how we turn talk into actual sustainable action. And I'd like to start off asking Florence about that.
That is indeed a very good question, because often when we go through a complex emergency, just like COVID is, or like Ebola was, or like conflicts are, we like to think about building back better. How do we take this opportunity to build back a system that is stronger than it was when we started? One way to do that is to say that the people who are going to be the governance people, the policy makers, the program makers should always have a Ministry of Health person with them. I think that the error that we make is we get funding that is for the emergency, and sometimes this funding may be provided to NGOs, for instance, who have a lifetime within the country. So the NGOs may come in and provide the intervention and then leave. And the intervention may be provided outside of the regular healthcare systems. But what we want to say now is let's build up the system so that it can respond to any other emergency that comes up. And that's why last week we had the executive board meeting where COVID and emergencies was discussed. Preparedness and response, and we're talking about mental health being prioritized. But within the same discussions, we also discussed the Global Mental Health Action Plan, and the two are tied together, because if we strengthen our response to mental health generally, but also ensuring that we strengthen the response to COVID. So I think that's a really important and good question that he asked. Or she asked.
Yes. Thank you. So, Carmen, how do we bridge that gap between talking about mental health being a priority and actually making it a reality in terms of better service delivery?
Yeah, I really think that the thing is that not to consider that this is going to be an exception. And one of the concepts that I'd like to strengthen here is flexibility and monitoring. So for me, it has to do with, we've seen that in mental health, we've seen a shift on the expression of symptoms. We are under constant change. We've seen these epidemics on cutting of the kids sometimes in some countries and then move to other countries. We've seen this cyberbullying that comes from one place and go to another. So we've seen this expression of symptomatology before, and some of this is going to be pathological, some is not going to be pathological. This needs to be addressed. Absolutely agree with what was mentioned before. So I really think that one of the things that systems need to do is to be taking a look at themselves, and being conscious that you cannot build a hospital and expect that this is going to function the same way 20 years later. This is not how things are working. So you need to make sure that you've got your plans on the 2-3 years, that you need to make sure that you've got plans at 6 months and at 1 year, and that you need to see what's going on in your environment. And you need to be able to shift what are the priorities and what are the needs. Without that, everything that's going to be very problematic. Things are not going to be useful. You cannot build wonderful hospitals for COVID that are not going to be used for nothing more than for that in the near future.
Thanks, Carmen. And one of the problems in the mental health world is that there are so many divisions within it, political divisions, ideological divisions, and I think that this sometimes stands in the way of really presenting that sort of unified front, which can sometimes be essential to promote change and to manage getting a truly diverse sort of mental health community, which at the same time can agree on certain principles or certain priorities has been incredibly challenging. I mean, Nev, do you think that the pandemic will change this, or do you think it's going to just be more of the same?
More of the same, or worse of the same, so to speak. I think kind of echoing my earlier comments, one of the problems is that mental health in the broadest sense is extremely broad. And, we can kind of fit under that umbrella prevention, again, sort of in the broadest sense that could include early childhood intervention, at-risk interventions. And, and then we have sort of, kind of people really suffering from struggling with, kind of long-term serious conditions. There's the sort of, in the US, kind of historically long-standing kind of tug and pull between sort of substance use services and mental health and competition over funding. So I think there has never, I'm not aware of any context in which there's been anything like sort of unity around this, kind of motley set of different issues, different needs, and scarce resources, where at some level we always end up in a situation of sort of competition for these scarce resources across different groups. So I don't think that COVID has improved that in any way. It may have made it worse, again, by sort of pulling public discourse more into this sort of very generalist mental health, which can end up, kind of siphoning off funds into, awareness initiatives, which I am not a particularly big fan of, right? I think when we have such kind of serious deficits and gaps and shortages of like really kind of fundamental needed services, and then put millions of dollars in some cases into splashy awareness campaigns, that's pretty problematic. So I would worry about that potentially happening.
Thank you, Nev. So the next question I have is about youth mental health. Now, the question is, what efforts need to be made to promote youth mental health education? Has COVID-19 been an accelerator for that? Now, I'd like to broaden this out a bit and just ask Florence to start with, what efforts have been made in the field of youth mental health in general, and how have they been accelerated or otherwise by the pandemic?
Ooh, that's a good one. Because I'm in the Africa region, and the region has the biggest population of youth globally. For most of the countries, we have up to 60–70% of the population being made up of youth. and these youth has the same youth have very low social capital. So many of them are out of school. Many of them are living in low-income neighborhoods. Africa, unfortunately, is going to have mega slums, and many of them actually feeling disenfranchised. So what the challenge I think that we face is how to pull. Right now, I don't think we have done much specific to COVID and youth. I don't think we have done very much. But last year, was it last year or 2019, WHO put out helping adolescents thrive, a guideline, and this is something that we hope to be rolling out. We also have another one on Live Life that focuses on suicide interventions. Unfortunately, many of the programs that we were thinking of rolling out in 2019 pre-COVID had to sort of be put on hold when COVID hit. And the other unfortunate thing is that most of the youth in a good part of the world may have had to change how they go to school, if they go to school at all. Very many countries have kept the young people at home. We've had very high pregnancy rates among young people, even as young as 13 or 12 years old, because they're sitting about at home with not much to do. And yeah, so I think it's a good question in that it makes me think we need to be doing something more. We haven't done enough for youth. I think that's where I'll stop. But we do have the guidelines and we do have the strategy for what we could be doing. It's how to implement it now. Once we start running around trying to respond to the acute emergency.
Thanks. And Carmen, is that reflected in the experience of high-income settings such as yours?
You know, I really think that what happens with youth is that we talk a lot about them. It's very rare that we get into the arena and to see what are the real problems they have. We talk to them how to prevent that, what to prevent that. But we should be going deeper in prevention of real problems. There are 2 or 3 things, such as bullying, that we know that's going on and happening. And that is one of the biggest predictors of any mental health problems, including severe psychiatric problems. There's another, such as substance use and abuse. That's absolutely linked with the early beginning of severe mental health problems. There's another that is how you deliver services, psychiatric services or early intervention services. If you don't go to the school settings many times, you lose the opportunity of delivering services in the real arena, in the real world. So my impression is that it's developed very differently, even within countries, even in countries with good with health that is in the high income. So sometimes the interventions that should be bridging things such as bridging schools and psychiatric care are not delivered enough. And this has to do with political thoughts of this comes here, this other thing comes here. So again, it's not something very complex. It's just trying to think through and to go to talk to the adolescents where they are and to ask them what their needs are, much more than inventing other stuff, but put services in the place where the people is living and where the people is developing the problem, the preventive interventions and the treatment interventions.
Thanks. Well, that brings me very nicely to our roundup question. Now, people who watch these webinars will know that I like the answers to these questions to be very brief, preferably 280 characters or less. So the roundup question today, which I'm going to ask all our panelists to answer, is: do you anticipate that the pandemic will move mental health up or down the global health agenda? Florence.
Mine is that mental health has already moved up the agenda with the endorsement of the resolution to prioritize mental health within emergencies. But are the countries ready? If a country is provided with, let's say, $1 million to do something this year on mental health, are they ready? What would they do with it? And unfortunately, I don't think they are. So let's work on country readiness, anticipating these huge amounts of money that are coming.
Thank you. Carmen, up or down the global mental health agenda?
I think that although it may seem that's going to be up because there's all this talking, my impression is that real mental health problems are going to be diluted into this wellness and go for the, you know, for improving the way people is living and so on and so forth. If this doesn't come with income, I mean, with the money support, and if this doesn't go to real severe mental health problems, this is going to be one cosmetic thing, much more so than a real improvement in mental health care.
Thank you. And finally, Nev.
Yeah, and my Twitter version of this, I think, would be up and down, sort of depending on the sort of set of conditions, and reinforcing longstanding inequalities, much as we've been discussing throughout the hour.
Thank you. So the feeling which I get from the panel today is that in terms of the public mental health response, in terms of the response of mental health services, it's really up to all of us as stakeholders to take control of the conversation much more, take control of the interventions, for instance, in the world of digital, and take control of planning for the future, for the next phase of the pandemic and of the global agenda on mental health. But that's unfortunately all that we've got time for today. However, you can check out the Global Mental Health website, United for Global Mental Health website, where you will find very shortly the video from today, as well as notes. And there will also be details of the next webinar. We hope you'll join us again. Thank you very much for joining us today. Thank you to all of our wonderful panelists. And for now, bye.
Bye-bye.
Thank you very much.